So let's move then to the next presentation, which is relates to the program of work from the Older People and Frailty Policy Research Unit. And in particular, we've got Patience Kunonga, who's going to tell us about health interventions and the unseen impact on equality. Take it away, Patience.
Okay, thank you very much. Can you see my screen?
We can indeed. Thank you. And we can hear you very well as well. Okay,
thank you. So I'm going to be speaking on behalf of my colleagues, Gemma Frances Spears, Catherine Richmond, Fiona Bayer, Peter Bauer, Barbara Hanratty, and Dawn Craig. And I'm going to talk about a rapid review that we did on health interventions and the unseen impact on equality. Oh, sorry, I've lost myself there. Right, so to begin with, I'll just give you a bit of a background on why we were doing this. So socioeconomic inequalities in disability-free life expectancy are a major and growing public health concern, with the situation likely to be exacerbated by the pandemic. So the expansion of disability that we're seeing, particularly among the poorest people in society, will have significant repercussions in the future, and poor health worsens quality of life, persistent barriers to education and employment, and greater levels of poverty. They're just mere likely for people living with disability compared to those who do not. So we were commissioned by the Department of Health to try and understand the gap in years lived free of disability between the richest and the poorest. And this is the rapid review that we did. So we began by scoping the evidence on long-term conditions that have NICE guidelines. And we selected 3 exemplar conditions from 22 identified previously by our colleagues, Carol Jagger and co. There was a review that they did prior to this. And the 3 that we selected are common and known to make a significant contribution to population level morbidity, disability, and mortality. And these were depression, osteoarthritis, and type 2 diabetes. We then focused on the interventions that are recommended in the NICE guidelines, particularly the secondary and tertiary prevention. So the aim of the study was to synthesize the available evidence to answer the following. We wanted to identify effective interventions that prevent or postpone the development of disability associated with depression, osteoarthritis, and type 2 diabetes, and then describe how the impact of interventions varies by socioeconomic status, and which interventions are effective for people of lower SES. So I'm just going to give you a brief round of the methodology that we used. This was typically systematic review methods, and I hope that most of you do know the process of screening and data extraction, so I'm not going to go deep into that. I will explain the inclusion criteria that we used, though, for you to understand what we were doing. So we included studies where the population included people reporting symptoms of or diagnosed with depression, type 2 diabetes, or osteoarthritis, and there was no age restrictions on these. We also included individual or population level interventions recommended by NICE that impact on the development of disability. Then we also included all reported clinical outcomes and sought to include studies where outcomes were stratified by a measure of SES and included a measure of the effect of size and, the measure of effect size, and where available, we included systematic reviews of preventative interventions And in the absence of eligible systematic reviews, we first considered randomized trials of secondary and tertiary preventative interventions. And where we couldn't find any evidence, we then went down lower the hierarchy of evidence studies to non-randomized prospective studies, and finally prospective cohort studies. So that we were just going down the chain to see where the evidence was. And as you can tell, these three conditions are very different. So our outcomes were also very different. So we didn't synthesize the three. So we sort of did three separate reviews for these because we couldn't synthesize them because of the outcomes, and the interventions were also different. So for each condition, we searched the guidance to identify recommended interventions. And then we examined the evidence cited in support of these interventions to identify any variation in outcomes by socioeconomic status. We then updated the reviews of evidence to support the guidance for each condition. So when we looked at the NICE guidelines, they were published at different times. So for depression, it was July 2008. For osteoarthritis, it was January 2016. And for type 2 diabetes, it was July 2012. So what we did was we ended up doing our extended search using the same search strategies that were in those guidelines, so that we were up to date, to get them up to date to 2022. So in where we found no data on outcome by socioeconomic status in the evidence, we then further searched for observational studies to update the guideline searches for and randomized controlled trials. We did not conduct a risk of bias assessment for this study. And for the studies that we found some evidence at the first point in reviews, we used the overall findings and conclusions of the reviews as our main data. So we didn't go into the individual studies of those reviews. So our outcomes were classified as favored disadvantaged populations. That means the intervention favored or improved outcomes for those in the lower socioeconomic status group, or favored advantaged populations. That means the intervention favored or improved outcomes for those in the higher socioeconomic status group, or no evidence or differential impact, meaning that the intervention had no difference in effectiveness by level of socioeconomic status. So our results, I've just put just a flow diagram there for each of the conditions. So I didn't do a proper Prisma type, otherwise I would have had to do for all three of them, but this is just to show you in quickly what we did. So between 2008 and 2022, approximately 8,636 studies were published, reporting evaluations of these NICE recommended interventions. So the 2,744 for depression, 5,137 for osteoarthritis, and 755 for type 2 diabetes. And I should probably say that for depression and diabetes, these were actual reviews. And for osteoarthritis, we went down, we went lower down the evidence chain to primary studies. So evidence about whether these interventions are successful in managing these long-term conditions is not in short supply, as you can see. Yet a closer examination of this evidence reveals a critical shortcoming I'll explain more of this. So of these studies, just 19, which was roughly 0.22%, considered the outcomes of intervention by socioeconomic status. So we had seven reviews in depression, 12 primary studies in osteoarthritis, and there were no studies reporting outcomes by SES in type 2 diabetes. And just a reminder that this was reviews, and by the time, from the limited time that we were given by Department of Health, we didn't have time to go down the lower evidence for type 2 diabetes. So we only stopped at systematic reviews, which is why we have no evidence for that. So just to make that clear, that we had only looked at systematic reviews for type 2 diabetes. So the evidence that we found for interventions for depression were that community-based mindfulness and mobile CBT produced similar outcomes across socioeconomic groups. School-based CBT may favor children from middle and higher socioeconomic status backgrounds, although there was contrasting evidence in a review of studies with greater risk of bias. Two of the reviews offered contrasting evidence about the effectiveness of self-guided CBT across socioeconomic groups, and internet guided CBT may offer worse outcomes for unemployed people compared to usual care. Our evidence for interventions for osteoarthritis, we found that surgical, education, and exercise interventions produced equivalent outcomes across socioeconomic groups or favored more advantaged populations. Self-management interventions favored more advantaged populations, and there was limited evidence on pharmacological interventions suggesting that outcomes were similar across socioeconomic groups, but the study data were not formally analyzed. So I'll just give you a roundup of what these findings mean. So the research evidence underpinning NICE recommendations for intervening in type 2 diabetes, osteoarthritis, and depression offered no robust information on how outcomes may vary with social disadvantage. And as I said, in our wider searches, we found limited evidence for social patterning in outcomes of the interventions for two of the exemplar conditions, which is depression and osteoarthritis, and no evidence for type 2 diabetes because of where we finished searching. So the limited evidence of social patterning was heterogeneous in study design, the population, comparable measures of socioeconomic status outcomes, and tended to show better outcomes for less disadvantaged people. So although NICE guidance aimed to improve consistency in the delivery of effective treatments and clinical outcomes at a population level, there is a lack of consideration of socioeconomic status within the evidence base. And this generates uncertainty about the impact of the recommended interventions for disadvantaged populations. So in conclusion, our study identified an important gap in the evidence needed to inform policy on improving the gap in DFLE between rich and poor. As we have seen, there's a dearth of research on how the impacts of long-term conditions vary for people living in different socio-economic circumstances. And one of the recommendations that we have made is that routine inclusion of measures of socioeconomic status in intervention studies should be considered to develop the evidence base at minimal cost and inconvenience. Thank you very much. And just to say that The project is funded by National Institute for Health and Care Research. Yeah.
Thank you very much, Patience. And again, perfect timing. So if anyone has got a question, could you please raise your digital hand? I'll start then with a question. I was just thinking, so where you have found that certain interventions have got different effectiveness by socioeconomic group, I was wondering, what does that mean? Does that mean that we should not use those interventions, or did you find evidence about the way in which the issues that give rise to those differences in effectiveness can be tackled through further interventions? So, for example, I think you've identified differences for web-based interventions between employed and unemployed. Was that because of access to computers? Was that because of training? Is what you do with the findings, I guess.
Yes, it's not quite clear what exactly is, because we were just reporting on the findings from other reviews. But yes, it's very important that we try to identify the causes of these inequalities, and which is why it's important that we include factors such as socioeconomic status when we're doing interventions, or other factors as well from Progress Plus, if you're all aware of those.
Thank you very much. Steve?
Yes, thanks. A really important question here is what socioeconomic status actually is. You can find very different patterns depending whether you're looking at, education or income or employment status and so on. If there's going to be a recommendation that socioeconomic status should be reported on, then it's quite important that someone makes some kind of sensible decision about what SES actually means. I wonder if you have any thoughts about how that should be defined, if it is to be a required reporting aspect.
I personally don't have a way of defining socioeconomic status, because like you said, some people tend to include education, income in socioeconomic status. And if you look at Progress Plus factors, those are actually outside of socioeconomic status as well, because socioeconomic status is listed as something separate to education, occupation, and stuff like that. So yes, we probably do need to have a definition of what we mean by socioeconomic status. I agree, yeah.
Thank you very much. Any other questions, comments? If not, thank you very much, Patience.